Welcome back to part 6 of our 15-part masterclass series. We are on a serious mission to decode superior labral pathology and absolutely master CPT code 29807. I'm Harshal, and I'm super excited you're joining me for this explainer. If you've been with us so far, you know we're building a rock-solid foundation in shoulder arthroscopy coding. Today, we're targeting one of the most frequently tested and honestly commonly misunderstood areas in orthopedic coding, the very top of the shoulder socket.
Here's a quick look at our agenda for this explainer. We'll do a rapid recap of Part 5, tackle slap versus Bankart lesions, break down the glenoid clock face, take a deep dive into CPT 29807, do a quick interactive knowledge check, and then wrap things up. Let's jump right in.
Section 1. A really quick recap of Part 5 and CPT 29806.
So just to jog your memory, capsulorrhaphy, which maps to CPT 29806, addresses tears in the anterior, inferior, and posterior zones. Think back to that spatial model we talked about. These specific repairs fall between the 2 and 11 o'clock positions on the glenoid clock face. This code is all about tightening up that joint capsule. Keep that 2 to 11 o'clock boundary locked in your mind because it's exactly the border we're about to cross today.
Section 2. Let's compare slap versus Bankart lesions.
All right, let's shift our focus to the top of the shoulder socket. What exactly is a slap lesion? Well, SLAP literally stands for superior labrum anterior to posterior. The labrum is just a ring of cartilage surrounding the socket. A SLAP tear happens right at the very top of this ring. The tendon of the long head of the biceps brachii attaches exactly at this superior spot. So when an overhead throwing athlete violently uses their arm, or if there's high-impact trauma, that biceps tendon pulls tight and can literally peel the labrum right off the bone, from front to back. Hence, SLAP.
This brings us to a brilliant rule of contrast that is absolutely crucial for us coders. Bankart lesions deal with anterior-inferior detachment, fundamentally related to joint instability. That's your 29806. On the flip side, the slap lesion is a superior detachment, driven by the biceps anchor at the top of the socket. That's our 29807. Confusing these two is literally the #1 reason coders select the wrong arthroscopic shoulder code, so keep this distinction clear.
Section 3. The glenoid clock face.
To translate all this anatomy into real coding confidence, you have to use the glenoid clock face. Surgeons usually don't just say superior or inferior. They speak in clock times. If the surgeon documents working in the 11 to 1 o'clock zone, boom, you're looking at a slap repair, and your mind should go straight to 29807. But if they move down into the 2 to 11 o'clock zones, you immediately switch gears to 29806. Let the documented clock times dictate your code selection. It completely removes the guesswork.
Section 4. Our deep dive into CPT 29807.
The official descriptor for CPT 2987 is straightforward enough. Arthroscopy, shoulder, surgical, repair of slap lesion. But you know how it is. Simple descriptors often hide a whole bunch of complex steps in the OR. To really understand the operative note, we need to know exactly what the surgeon is doing inside that joint.
A classic slap repair is basically a 4-step dance. First up, arthroscopic visualization to confirm the tear. Second, the surgeon debrides and prepares the superior glenoid bone bed. They actually have to rough up the bone slightly to promote a strong healing response. Third, they insert suture anchors directly into that bone. And finally, step 4, they pass sutures through the torn labrum and tie knots to lock that biceps anchor firmly back into place. When you see these steps concentrated in that 11 to 1 o'clock zone, you've got a beautifully documented 29807.
Okay, listen closely, because this guideline is an absolute game changer. Any localized debridement done in that same 11 to 1 o'clock zone is bundled right into the repair code. Remember that second step we just talked about, preparing the bone bed? Because that debridement is a necessary part of the repair itself, it's totally inclusive. You absolutely cannot separately report a debridement code for work done at the exact same anatomical site as the slap repair.
Section 5. Time for an interactive knowledge check. Let's see what we've learned.
Let's test your active recall here. The orthopedic surgeon documents an arthroscopic repair of a type 2 slap tear located at the 12 o'clock superior labrum using 2 suture anchors, along with extensive debridement of the superior labrum. So what CPT coder codes are we reporting here? Think about the clock face position and that specific wording around the debridement.
If you said 29807 only, you hit the nail right on the head. Why? Well, that 12 o'clock position lands us squarely in slap territory. And as for that extensive debridement,
Actually, it doesn't matter how extensive they say it is. Because it happened in the exact same zone as the slap repair, it is completely bundled. Reporting a separate debridement code there would be a big bundling violation. Awesome job if you caught that.
Section 6. Let's wrap this up with our key takeaways and a quick teaser.
Let's lock in today's knowledge. Your biggest takeaway? Always trust the clock face. 11 to 1 o'clock means a slap repair and CPT 29807. 2 to 11 o'clock points to a Bankart repair and CPT 29806. And never forget that localized debridement at the repair site is always inclusive. Make sure you join us for Part 7 because we're taking on loose and foreign body removals, and we'll be dissecting the very strict greater than 0.5 centimeter documentation rule for CPT 29819. You won't want to miss it.
I really hope this explainer gave you a clear, structured way to accurately code these complex shoulder procedures. Next time you're staring down a shoulder operative report, you won't be guessing the anatomy. You'll be confidently reading the clock. Decode Healthcare with Harshal.